Hi everyone, our subject today is pubertal delay. Basics. Pubertal delay is the absence of secondary sexual characteristic, testicular enlargement in boys or breast development in girls. This is considered to be 13 years of age for girls and 14 years of age for boys. Development of pubic hair is usually not considered in the definition because adrenarche, adrenal gland maturation, may occur independently of gonadarche. Pubertal delay may also occur if progression through puberty stall or takes more than 4 years between first sign of puberty and completion. In contrast to boys, pubertal delay in girls more frequently represented underlying pathology. Malnutrition is a risk factor for delayed puberty. Girls with some sexual maturation but with the primary amenorrhea, please see previous lecture of primary amenorrhea. History. A thorough history of past medical condition, past growth pattern, and family history is essential. Family history of childhood, growth pattern, and age at pubertal onset of parents, late menarche in mother, or delayed completion of adulthood in father. A complete review of system to uncover an underlying chronic disorder such as inflammatory bowel disease, thyroid disorder, celiac disease, or eating disorder is necessary. Bilateral cryptorchidism or small penis at birth and hyposomia or anosmia may suggest hypogonadotrophic hypogonadism. A history of chemotherapy or radiotherapy may indicate primary gonadal failure. Request and exam a long-term growth chart. Constitutional delay of growth and puberty will generally exhibit a consistent low percentile of growth throughout childhood with linear growth deceleration in prepubertal period. A growth rate is within the prepubertal normal range. Gonadotropin or gonadal causes will generally present with normal growth in childhood, but no increase in growth rate during the expected pubertal spurt. Obtain history of progression of secondary sexual characteristic. Adolescent with complete gonadal or gonadotropin deficiency will not enter puberty unless initiated by exogenous hormone. Those with the constitutional delay will progress at a normal rate after initiation of puberty. In pubertal constitutional delay, both adrenarche and gonadarche occur later than average. In isolated hypogonadotrophic hypogonadism, adrenarche will usually occur at a normal age. Medication history may be useful. Use of glucocorticoid or cytotoxin. Assess nutritional history to evaluate for chronic malnutrition or eating disorder. Physical exam. A thorough physical exam is essential. Pay particular attention to the following elements. Thyroid exam, neurological and fundoscopic examination to check for intracranial pathology, genital examination and sexual maturity rating, tenor stage, breast exam for girl, pubic hair, penis, testicular exam for boys, internal gynecological examination for girls with amenorrhea may be indicated. The first sign of puberty in boys is when testicular length is more than 2.5 cm, which is 4 cc volume. The first sign of gonadarche in girls is breast development. In girls, determine whether there is marked discordance between pubic hair and breast development, which means adrenogen insensitivity. Assess for physical sign of Turner syndrome or Klinefelter syndrome. Examination include careful measurement of the height, weight, arm span, and body mass index. Pattern of growth, velocity, and sexual maturity rating, tenor stage should be assessed. Body proportion may be helpful with the growth hormone deficiency. Height age is less than weight age. Enochoidal proportions, arm span, height, long legs are noted in hypogonadism. Androgen effects include phallic growth, increased testicular size, sexual hair, voice change, increased stature and muscle mass, hairline recession, and body odor. In girls, excessive androgen may lead to acne, hirsutism, or clitoromegaly. Estrogen effects include vaginal cornification, discharge, breast development, uterine size, and onset of menarche 2 to 2.5 years after breast budding. A careful CNS examination should include identification of midline facial defect and test for olfaction, anosmia, hyposomia, Kalman, and Kalman syndrome, as well as visual acuity. The presence of gynecomastia and galactorrhea should be noted. Skin examination include caffeolate spot in cases of neurofibromatosis, tanning in adrenal insufficiency, and ichthyosis could be congenital ichthyosis, Kalman syndrome. Stigmata of specific syndrome may be identified on initial exam like Turner syndrome, Fragile X, Prader-Willi, etc. How to approach to patient with the pubertal delay. After performing history and physical examination, patient need FSH, LH, bone age, estradiol in female, testosterone in male, prolactin, free T4, TSH, according to the result. If there is hypergonadotropic hypogonadism, increase in FSH LH ratio, patient need karyotype. If it is abnormal karyotype, either Turner syndrome, mixed gonadal dysgenesis, or Klinefelter syndrome, or normal karyotype, differential diagnosis may include a pure gonadal dysgenesis, Noonan syndrome, androgen insensitivity, 46XY disorder of sex development, premature gonadal failure in cases of autoimmune ovaries, resistant ovary syndrome, galactosemia, myotonic dystrophy, Fragile X syndrome, carrier, post-infectious in cases of mumps, gonadal injury, surgery, torsion, gonadal toxin, radiation, chemotherapy, congenital anarchia, vanishing testes, bilateral cryptorchidism, enzyme defect, testicular dysgenesis syndrome. If the primary investigation show hypogonadotrophic hypogonadism, low or normal FSH, LH, which is pre-pubertal level, is there family history of delayed puberty, which is bone age equal to height age? If it is yes, this is constitutional delay. If it is no, is there stigmata of specific syndrome? If it is yes, could be Prader-Willi syndrome, Lawrence-Moon-Vidal syndrome, Kalman syndrome, multiple lentiginous Mobus syndrome, congenital ichthyosis. If there is no stigmata of specific syndrome, patient need complete blood count, ESR, C-reactive protein, chemistry profile, electrolyte, ultrasound urine analysis, free T4, TSH, insulin-like growth factor 1, insulin-like growth factor binding protein 3, consider celiac secrete, tissue transglutaminase, IgA, HIV test, stool for occult blood, and calprotectin. Is there evidence of clinical hypopituitarism? If it is yes, there is evidence of hypopituitarism. Patient need brain MRI. Differential diagnosis, hypopituitarism, Causes could be idiopathic, tumor, craniopharyngioma, adenoma, prolactinoma, congenital malformation, radiation therapy, post-infectious, head trauma, hydrocephalus, isolated growth hormone deficiency, isolated gonadotropin deficiency in cases of Kallman syndrome. If there is no clinical evidence of hypopituitarism, differential diagnosis could be chronic illness, inflammatory bowel disease, or other endocrinopathies, malnutrition, anorexia nervosa, eating disorder, excessive exercise, depression, stress, substance abuse. Recommended investigation: complete blood count, C-reactive protein for anemia with high C-reactive protein suggests Crohn's disease. Screening a blood test for celiac disease, hormonal assay level of FSH, LH, gonadotropin releasing hormone, thyroid function test for suspected thyroid disorder, chromosomal analysis for suspected Turner and Klinefelter syndrome, breast X-ray for bone age, pelvic ultrasound scan to detect ovarian cyst or tumor, testicular ultrasound for tumor, radiologic investigation for suspected cases of Crohn's disease, cranial MRI of the head for hypogonadotrophic hypogonadism to exclude CNS pathology. Alert: no test can make a definitive diagnosis of constitutional delay. Consultation with the specialist or experienced laboratory personnel is recommended before obtaining pituitary stimulation test, as they may require special conditions. Only the spontaneous onset of puberty confirms the diagnosis of constitutional delay. Top tips: when using the Tanner growth chart for pubertal stage in children with the delayed puberty, the heights of the parents and the sibling should be obtained. Children with constitutional delayed puberty can be reassured. This is a normal variant of puberty, timing with a good outcome for final height and future reproductive capacity. Puberty can be assessed by bone age, breast X-ray. If bone age is within 1 year of the child's age, puberty has not or has only just started. Bone age within 2 years indicates the child is in puberty. A case of a very thin child with the delayed puberty suggests possibility of anorexia nervosa or excessive sport activity, while obesity may suggest Prader-Willi or Lawrence-Moon-Bedal syndrome. In girls with the delayed puberty and short stature, Turner syndrome should be considered. Pelvic ultrasound and chromosomal analysis should be carried out. High level of FSH and LH are found. Remember that girls with the Turner syndrome achieve normal adrenarche and axillary hair at appropriate age. They do not develop menstruation. Hormonal treatment is often indicated in boys in constitutional delay. Age with treatment, age 11.5 year and testosterone age over 13.5 years. And in girls with the ethylene estradiol or estrogen, if the pubertal delay and or growth are causing distress or school underperformance. Red flag: while the principal cause of delayed puberty in boys is constitutional, girls have more frequent pathologic causes: anorexia nervosa, chronic disease, intensive exercise, or chromosomal abnormalities. Constitutional delayed puberty is a diagnosis of exclusion. Therefore, alternative causes should be considered, including functional hypogonadotrophic hypogonadism causing transient delayed puberty, malabsorption, renal insufficiency, anorexia, structural hypogonadotrophic hypogonadism causing permanent delayed puberty in CNS pathology, and gonadal failure in both sexes. Be aware that chronic disease like Crohn's disease and celiac disease may initially present as delayed puberty. All girls with an inguinal hernia should undergo a pelvic ultrasound scan examination before the operation to exclude testicular feminization, currently termed androgen insensitivity syndrome. In girls with otherwise normal sexual maturation but delayed menarche and galactorrhea, prolactinoma is likely. Urgent prolactin level and MRI of the brain should be considered. Turner syndrome. Stigmata of gonadal dysgenesis syndrome like Turner syndrome include short stature, pigmented nevi, high arched palate, low hairline, shield chest, ptosis, cutis laxa, pterygium coli, webbed neck, shortening fourth metacarpals, cubitus valgus, heart murmur, nail changes, and deformed ears. There may be a history of congenital lymphedema. The 45X karyotype is the most common, but girls who are not diagnosed until their teens may have fewer examination finding, and mosaicism 45X with the 46XX may be present. Mixed gonadal dysgenesis is a common cause of ambiguous genitalia in newborns. The karyotype usually shows mosaicism. Patients often have a female phenotype and features of Turner syndrome. Some patients have no sign of masculinization, whereas in others there may be prepubertal clitoromegaly with the further virilization occurs in puberty. Klinefelter syndrome is the most common cause of testicular failure in the karyotype is usually 47XXY. Mosaicism are seen in 20%. The patients are usually tall and thin. Testes are small. There is mild mental retardation and gynecomastia may be present. Pure gonadal dysgenesis variants include XX or XY karyotype with normal stature and streak gonad. In XY gonadal dysgenesis, Swyer syndrome, children have a female phenotype, but at pubertal age, breast development and menarche fail to occur. Nonan syndrome has similar feature to Turner syndrome, but the difference from Turner: normal karyotype, autosomal dominant, 50% to 80% have pulmonary valve stenosis or hypertrophic cardiomyopathy. Androgen insensitivity. The genetic male with the androgen insensitivity disorder of sexual development, testicular feminization, appears phenotypically female with the primary amenorrhea, breast development, and absence of pubic hair. There is wide variation in the degree of androgen resistance. Level of LH are usually elevated, but FSH level may be normal because estrogen from the testes may suppress it. A cause of primary ovarian failure may be autoimmune oophorytis, which is associated with the autoimmune endocrinopathies, thyroiditis, Addison disease, diabetes, and may be screened for with the anti-ovarian antibodies. Resistant ovarian syndrome is due to defect in the FSH or LH receptors. Premature gonadal failure may be associated with galactosemia, myotonic dystrophy, and Fragile X-associated syndrome. Anorchia is the absence of testes and must be distinguished from bilateral cryptorchidism. If testes cannot be palpated in boys with the normal external genitalia, they have cryptorchidism. The testes are usually undescended or rectile, but rarely no testes are found even after investigation. This syndrome is known as vanishing testes, congenital anorexia, or testicular regression syndrome. In cryptorchidism, owing to compromised Leydig cell function, normal testosterone level may only be achieved with the elevated FSH and LH level. Irradiation or chemotherapy may also cause gonadal injury. Enzyme defects include 17-hydroxylase deficiency and 17-ketosteroids reductase deficiency, which result in hypertension, adrenal insufficiency, and deficiency of androgen and estrogen. The environmental influences that have been implicated in the testicular dysgenesis syndrome include environmental chemicals that may act as endocrine disruptors like bisphenol A, phthalates, insecticide, phytoestrogen, and other chemicals. However, the evidence is only suggestive, not conclusive. Constitutional delay is the most common cause of delayed puberty and is brought to the medical attention more often in boys. There is a family history of delayed puberty, consistent growth velocity, and normal examination. Usually the bone age equal height age, which is less than chronological age. To make a presumptive diagnosis of constitutional delay, pathology must be ruled out. Physical examination include genitalia, anatomy, and sense of smell must be normal. There should be no sign or symptoms consistent with the chronic disease. History include nutritional history and review of the system must be negative. Screening blood work must be negative. Growth is low for age, but height and growth rate are within pre-pubertal range. A delay in bone age is characteristic but not diagnostic of constitutional delay. Genetic syndrome. In Prader-Willi syndrome, there is obesity, hyperphagia, short stature, and mild mental retardation. The hypogonadism is hypothalamic. Lawrence-Moon-Vidal syndrome is associated with a mild mental retardation, retinitis pigmentosa, syndactyly, polydactyly, and obesity. Pubertal delay is due to deficient gonadotropin releasing hormone, resulting in decrease in FSH and LH. Kalman syndrome, gonadotropin releasing hormone deficiency, is associated with the midline defect, cleft lip, palate, congenital deafness, deficient sense of smell, and sometimes ichthyosis. Multiple lentiginous syndrome include cardiac defect, urological abnormalities, short stature, and deafness. Other syndrome with the hypogonadism include Moebius syndrome and congenital ichthyosis. Endocrinopathies include hypothyroidism, diabetes insipidus, Cushing disease, Addison disease, and diabetes mellitus. In prolonged hypothyroidism, FSH and LH may be paradoxically increased. Hyperprolactinemia is more common in girls. It may be primary idiopathic pituitary adenoma or secondary to disruption of the pituitary stalk or hypothyroidism. Galactorrhea is present in 50%. Hypopituitarism. Clinical evidence that may suggest hypopituitarism include symptoms like growth failure, anosmia, midline facial defect, visual disturbance, and galactorrhea, hyperprolactinemia. Hypopituitarism with multiple tropic hormones deficiency is usually idiopathic. However, it may be due to a tumor, trauma, congenital malformation, septo-optic dysplasia, infiltrative disease, tuberculosis, sarcoidosis, histiocytosis X, and cranial radiation. Neuroimaging MRI should be considered to exclude these conditions. Patients with the isolated growth hormone deficiency usually have pubertal delay. Isolated gonadotropin deficiency is associated with the number of genetic disorders, including subset with the anosmia, hyposomia, Kalman syndrome. Systemic illness may affect both growth and pubertal development by gonadotropin releasing hormone suppression. Malnutrition, chronic illness such as renal failure, inflammatory bowel disease, celiac disease, recurrent infection, sickle cell disease, and malignancy may be causes. Thank you for your listening.